Thank you all for coming to the QVIC forum today. My name's John Spurtis, and I'm sorry I can't put my video on. There's something wrong with my camera, but I'm very excited to welcome you to today's topic, which is really health in all policies. And towards that end, I wanted to give a little bit of background about the UMKC's Healthcare Institute for Innovations and Quality and our Quality and Value Innovation Consortium vision, which is that we live in an era where hospitals are working and are evolving to become learning healthcare systems, entities that study the way they deliver care, find opportunities to improve upon it, and then continue to implement and disseminate changes in the way they deliver care to improve the outcomes of their patients. And we want this to evolve from a learning hospital or health system to a completely learning healthcare network where we work with all of the providers in our community and we begin to start sharing strategies that are working so that we can collectively improve the value of healthcare in the Kansas City region. And so to achieve this goal, we have three sort of main activities that we pursue. The first are demonstration quality improvement projects. And this is a map of the region and the hospitals that are participating in the KC EPIC project, which is an effort to address opioid crisis in the emergency department and transitions in care and heart failure. We also have and will be expanding our training and implementation science, which is the study of how we understand the barriers and facilitators of changing routine practice and can measure and leverage those insights to improve the way and the rapidity in which we evolve and improve the care that we deliver. And then this is the QVIC forum. And this is an opportunity for our entire community to learn from each other and to hear different perspectives about some salient issue confronting healthcare today. And this is a list of the forums for this year. And today we're here for health in all policy. And so I'm charged with providing a little bit of background for this. And so it is widely understood and appreciated and a source of great consternation that the US fails to deliver high quality, equitable healthcare. And when we think about healthcare, we really ought to be thinking about health. And improving health requires not only universal access to high quality care, but attention to factors outside of the health sector that make individuals and communities sick. And the WHO a few years ago released a report that really crystallized the concept that health is neither created or maintained solely within the healthcare sector. And so this requires public policy and other diverse strategies to become an important lever for affecting the changes to improve health. And as an analogy, I wanted to share, I had the privilege of working with Kamara Jones, and she has this concept of a cliff analogy, which I really like. And, patients for a long period of time can live in a state of relatively good health. But at some point, they can fall off the cliff. And, this can lead to catastrophic healthcare deterioration. And it becomes reliant on sort of the healthcare system to pick people up after they've fallen. And these deteriorations disproportionately affect people of color, low socioeconomic status, women, et cetera. And it's very costly to the productivity of our society. And so we need to think about strategies to try and prevent people from falling off the cliff. And certainly one that we talk about is creating a safety net or a trampoline that can capture patients who have fallen. And secondary prevention is an effort to do this. Obviously, people fall through the safety net and fall through the cracks, and they've already fallen off the cliff and suffered some healthcare deterioration. We can alternatively put a fence in front of the cliff. And, this is to prevent the falls. And this is what primary prevention and increased access to care are about, is trying to create some barrier to falling off the cliff and creating access to care. But, really what we need to be thinking about is how do we move people further away from the cliff? And this is addressed by putting attention on the social determinants of health and health policy and health in all things. And that's what this forum is about today. And, the CDC has a very rich website about health and all policies, and this is a copy of their resource center. And I think it's a good thing for, as we get stimulated by today's speakers, to think about tools and strategies that we might seek to adopt in our community to help support health. And so today, we're very, very fortunate to have an extraordinary group of speakers. We're going to hear the research perspective from Lana McKinney, who will be talking about keeping health equity at the forefront of health policy. She'll be followed by Tatiana Lin, who will talk from the Kansas research perspective about advancing HIP through health impact checklists. Then we're very privileged to have one of our steering committee members, Marvia Jones from the Kansas City Department of Health, talk about barriers in our own backyard. And then we're also very, very privileged to have Corey Coco talk from a regional health policy about cross-sector work to step out of the silo and into the community. And then Stacy Farr will lead a question and discussion panel afterwards. So I'd like to really thank all of our speakers and all of you for participating. And at this point, I'd like to turn it over to Lana.
Thank you, Dr. Spertus. I am going to share my screen. Good afternoon, everyone. Hopefully you've had a great afternoon so far, starting today. Let me quickly, my name is Lana McKinney, and I represent Right Hands Consulting as a geriatric public policy consultant. I also serve as a senior policy analyst for ASTO, as well as on the KC Health Commission, which you'll hear about momentarily. Let me first acknowledge that I do not have any financial disclosures for this presentation. Also, anytime we talk about health equity, I do want to acknowledge that I am an African-American woman. So you will hear some of the things I talk about through that lens, as well as acknowledging the native land that we are on in this digital space. So let me first say all of those things. Again, welcome. So really quickly, what I want you all to take away from this brief presentation is sort of my purpose with the Community Health Improvement Plan, also known as the CHIP, some of our findings, recommendations, and some of the goals that we set. So when we talk about health policy, something specific that we worked on under the Kansas City Health Commission. One of the things that we keep at the forefront of our mind as serving on the committee is that the essence of global health equity is the idea that something so precious as health might be viewed as right. And so I want you all to sit with that quote and really think about all of the work that you all do with health and all policies and all of the communities that you serve, really thinking about keeping health equity at the forefront of your mind and your work. So let me kind of back up and start. I serve as the community co-chair for the Kansas City Health Commission, Kansas City Community Health Improvement Plan, which is also known as the CHIP. So I'm the CHIP committee co-chair. I serve with Dr. Joy Leitner, who is a health commissioner. And so I'm not sure if you all are familiar, but really quickly, the Health Commission was created by the mayor's office down at the city, just specifically talking about how to keep health, safety, and well-being residents and visitors of Kansas City, how to keep their health at the forefront. So what the CHIP is essentially is a plan, right? So if we think about what we want to do to improve the health outcomes for all Kansas Cityans, whether they're visiting or actual residents. And so what we created was a long-term plan, and it lasts about 5 years, looking at activities, assessments, programs, policies, things that we can actually do and put into a plan that are actionable. And so typically we had a downstream prior to 2022. We more so looked at outcomes, what individuals could do, how you could look at chronic diseases, specific issues, and address those things within the community health improvement plan. So really taking it at a granular level. What we decided to do this time and this go around for the next 5 years is to sort of flip that on its head. What we've learned or what we've figured out in the research process is that CHIPs have not always been successful, or they've only been partially successful. And so we challenged ourselves this go around to say, you know what, as a committee, we need to intentionally look at where to begin quality of life work. And that begins with health equity and putting equity at the forefront of our plan. So what our committee decided to do was we're going to look at health assessments. We're going to have listening sessions. We're going to look at a quality of life survey. And we did all of that by using a few tactics. One is called root cause analysis. So we use 5 whys. Why is the life expectancy in this neighborhood low? Well, why is there, lacking some sort of grocery store? What, some sort of basic need for a community member? Why is it health outcomes are linked to education? And what we decided in looking at the purpose of this in this root cause is that racism and systemic bias were at the root of it. And so knowing that structural discrimination was at the root of everything that we kept finding about why, we decided to root our community health improvement plan in looking at structural discrimination and structural racism and figuring out how we could base sort of goals, outcomes on that. Something else we used to, and I'll briefly talk about, is something called a NOT chart. So there was data out there talking about what we needed to do. There was also data available that we knew we could move forward in and put a plan together, but there were things we needed to know. And again, we asked ourselves the 5 whys. A lot of folks had opinions. We heard opinions from across, every sector as well as community members. And then we looked at what we thought we needed to know or what we think we need to know to move forward in that. And so what we sort of discovered out of the community health improvement plan were these 6 priority areas. But in knowing these 6 priority areas, it won't move forward if we don't have equitable enforcement of these priority areas and really tangible goals. So with this CHIP, we were specific in our intentional efforts to have a priority area, have a goal, reach out to community members, reach out to organizations that were in the Kansas City area looking to improve the health outcomes of all Kansas Cityans by using public policy and by using programmatic strategies to move those things forward. So one of the things that we talk about findings and approach is that we did a lot of sort of multi-layered cross-sectored engagement. We looked across generations. We looked across zip codes, low density, high density, low life expectancy, high life expectancy, to figure out what systemic barriers were in place that we could actually approach and have a plan for. And so when we thought about how to move this forward in health equity and health policy, we established our goals rooted in health equity. We called out specifically in the plan practices in public health, anti-racism practices, anything sort of that we needed to do as a recommendation and a finding that we could move forward the overall health of Kansas Cityans. Also, we wanted to, like I mentioned, use a multifaceted approach, but evaluation was at the core of that. We're going to use, and Dr. Spertus mentioned previously, using implementation science to really get at the root of how we can go about getting the community what they need. And I'll quickly say what our sort of motto is how do we get what works to the people who need it with the greatest speed, fidelity, efficiency, quality, and relevant coverage. So when we want to make those approaches for programmatic work or policy work, we want to make sure that, again, we look at the structural pieces, but then also how do we kind of move past the red tape of what needs to happen in order to create health policy and healthy communities. So again, I briefly mentioned our recommendations out of the CHIP. We're looking at calling out institutional biases and discriminations when we talk about public health crisis. Obviously, we are all still in a pandemic, and we want to make sure that in the event another pandemic, we pray doesn't happen, but does, that we look at that, any sort of biases immediately and sort of upfront. When we create policies, really looking at the language that we use in our plans and inside of our programs that can help move forward the overall health of Kansas City and public health as well. I want to say with our CHIP, we're looking at funding and infrastructure. So understanding that in order to move some of this work forward, you need funding. And what that looks like from a policy perspective could be a budgetary line item, could be a rule within our health departments, and then collaborating with some of those organizations in order to make that happen. And then public accountability. We understand that the CHIP was written by a number of scholars who participated, as well as community members, community organizations. And the ultimate goal is to have it written by the community, because we know what Kansas Citians know what they need, and they can put that down on paper. And so our job, as now that we have a plan available, is to really look at actionable items, goals, priorities, and then attach those with accountability and making sure public accountability, so you can see the health of your community changing. You can see education changing. You can see transportation changing. You can see COVID-19 outcomes changing. All of those things you want to see happen. But then also, we know that the power is in policy. So once you create a goal and you meet that goal, how do you sustain it? And so that's where we're going to we have the community health improvement plan to help back up what it is we look to accomplish, but then it's an ordinance, right? So the next step with that is, hey, we are able to do a training. It was successful for these reasons. It created better health outcomes for these specific zip codes, neighborhoods. Is there a way we can make this training permanent? Is there some sort of legislative lever we can use to move that forward? And so one of the things I really want this group to know is, when you create a policy, or when you really look at public health policy in a research base or in a programmatic plan base, you want to draft it in such a way where it's tangible items and goals, but then really think about the implementation of it. Have we talked to everyone at the table? And if they're all talked out, can we still speak and put their voice into our plan? But then really remembering, how do we get what works to the people who actually need it? So when you're engaging interested parties, you really want to have the people, the community, the institutions, even though they may not have health equity at the forefront of what they're doing, they can understand how crucial health improvement is. And so I know we'll have time for questions at the end, but if anyone has any in the chat, how could I provide you with any more clarity? And I will now turn it over to Stacy for our next presenter.
Sure. Yeah, thank you so much, Lana. That was phenomenal. Really interesting to hear about the work you're doing in the community, and wise words of wisdom with the implementation science. You're preaching to the right choir here with that, and how we actually can kind of hope to move the needle in getting some of those recommendations put into practice. So yeah, a reminder to everyone, please drop any questions or comments into the chat. But here we'll turn to our next speaker, who is Tatiana Lin with the Kansas Health Institute. She's here to speak from a Kansas research perspective on advancing health in all places through health impact checklists. So the floor is yours, Tatiana.
All right, well, thank you so much for the opportunity to be here today. And I will talk about one of the ways to advance health and health policies through a specific tool called Health Impact Checklist. So if you're not familiar with us, I'm with the Kansas Health Institute. We are located in Topeka, and we are a health policy nonpartisan educational organization and been around since 1995. So just to ground us in a definition of health and health policies, it comes from the AASHTO toolkit. And it's basically think about health and health policies is a collaborative approach that clearly integrates and articulates consistently health considerations into decisions and policies across all sectors with kind of this bigger vision to improve the health of all communities and people. And so this slide represents the key principles or pillars of the health and health policies. So when we're really talking about health and health policies and creating our efforts, our plans and decisions, we need to keep those pillars in mind. And some of those just been discussed by Ms. McKinney. So really about cross-sectoral collaboration, making sure it benefits multiple partners, we're engaging, authentically engaging stakeholders. We're creating our processes and changes in a way that health and equity is becomes a part of a systemic consideration in promoting health and equity. And so one of the important, why is it important? Because in regular days, policymakers and decision makers in different sectors have, make a lot of decisions, and they do affect how our communities look like, how they're shaped, quality of life. And so in some cases, those issues appear not to be connected to health, but they may have important health considerations, both positive and negative. If you, for example, think about an ordinance that focuses on addressing dangerous structures in the community, it might require repairing and removing them. On one hand, it can have positive impact on health through addressing or decrease exposure to mold, allergens, and lead. In the meantime, it might have negative impact on health as well if it requires to repair property, and individuals who need to repair property do not have means to do so. So it can put undue burden to them and require trade-offs, kind of other needs. So we need to make sure that those decisions do consider health and equity on an ongoing basis. So the key question that we want folks to think about is, what are some any project plan and policy, how do they affect all of those different issues in the middle column? How they affect housing, air quality, noise, safety, and when they get changed by the policy or the decision, what does that mean for health and equity? And so the question is, how do we get decision makers to think about this question on an ongoing basis and consider those type of implications of a policy? And that what brings us to this tool that we have developed called Health Impact Checklist. And you see the kind of the front cover of that. And if you have a phone, you can scan this QR code just by placing your camera on it, and it will pop up the tool for you. Hopefully it works the way it's intended. And so the tool is really a way to help understand and connect those dots between decision and health outcomes. So what are the key components of the tool? One thing that we came up with is creating a structured template. And this tool was actually based on kind of other tools available in the field. You might have heard about health impact assessment, health notes, health lens analysis. So we were able to look at all those tools that already existed in other states, compare and contrast them, and ask ourselves a question: what is missing? How we can provide more value with this tool? So one thing we decided is doing the structured template that is very clear for folks what things to fill out, and especially those who work with the logic models. It has a checklist component, and here I'm kind of displaying the checklist component that helps to ask a question: how is the policy impacting those determinants? It also has an opportunity to think the populations that are impacted. And have a couple other features, including a one-page template summary. So we know that elected officials in a lot of cases, have very busy and cannot read big technical report. So it kind of provides this one-page summary. It also has a user guide, so kind of walks through how to complete this tool specifically. and answer some kind of common questions, as well as some examples of actually completed tools in 3 of the areas on the local, county, and state level. So just to give you a little bit more kind of understanding what you can expect from a completed tool, I included a few slides that kind of walks through the example of a specific policy, so you can see the kind of the outcome or the result of that. So it's an actual policy being done in Hutchinson, Reno County, and the policy focused on suspension of disconnections of services due to COVID-19. And so it was for a short period of time between March and May, and was then extended to June. And so the goal here was to understand how is that policy might impact health. So basically the question is, if you have uninterrupted access to water services resulting from this policy, how would that impact health broadly, both positive and negatively? So, so the first question that tool helps to address or answer is, what is the connection between this policy and social determinants of health? And so that brings us to that table that I showed a little bit earlier. This table was created based on Kaiser Permanente kind of social determinants model and Healthy People at that point, 2020, but now 2030. So it has this 5 different areas: economic stability, environment, education, and others. And each area has kind of several conditions. And again, we're asking ourselves a question: how would this policy impact any of those conditions? So what we have identified through some literature review that some of those conditions in the red boxes here might be impacted by this policy. So we're talking about housing instability, food insecurity, sanitation, and others. The tool also allows to add other conditions. So it has just kind of a starting point, but then it allows to add additional conditions as well. So just to give an example, what we mean by impacting those conditions and how to kind of provide more details on that. So after determining a list of conditions, the tool lets you to unpack each one of them. So this one is, we identified that the impact of this policy on custody of children, and actually that was not intuitive, but what we have learned from the literature, that lack of running water at home can be considered exposure to hazards and be a reason for parents or guardians to lose custody of children. And so the removal of children, as we know, from home can be disruptive and have some negative health outcomes. And because the policy for that period of time would not have this interruption of services, it can actually create potential positive impact on health. And so for this particular one, it also allows to kind of put a check mark where we think the overall impact is going to be, which will be positive from that particular angle. So again, it just follows this logic model, starting from the impact of the policy and the condition to the overall health outcome. The next piece that this tool allows to do is to think about, what about population? Which populations might be impacted? We know that some populations might be disproportionately impacted by the policies, especially negatively. And so we want to make sure that we are very clear what that means for certain groups. So what this tool does, it actually offers a list of populations that might be impacted. So my individuals might not think necessarily which groups they need to be thinking about. It also gives a nod that they should be thinking about those who are at high risk for poor health as a result of barriers that they experience to social, economic, political, environmental resources. So the tool provides a list of population that I have here. It's been created using multiple resources. And really, again, encourages those to complete the tool, think through each of those groups and ask a question: how would this policy impact some of those groups, and what the impacts might look like? This list, we try to be comprehensive, but we understand that the list might not fully with all the population might be considered. And those who complete the tool don't have to address each of the population. They just need to really think about the most critical populations that might be connected to this policy. So in practice, how it might look like, again, the same format of the table. It starts with the condition. So chronic condition is another that's been identified in connection to this policy. So the policy might have mixed impact on chronic stress. Positive might be elevated fear associated with water shutoff during the grace period. However, the accumulation of utility debt during the grace period will also cause stress. So because according to this policy, the debt is not going to disappear. It's going to be just, you still have to repay this over several months once the grace period is over. So the group of individuals, low-income individuals, might be especially affected by that. And then we know that there's impact of stress related to kind of the chronic stress, health outcomes related to that are negative. So we rated this as a mixed impact. Again, during the grace period, it's going to be some positive related to that. And then after the grace period, there might be some negative associated with that. So what the tool does next is, if your findings are mixed or negative, is to allow to create recommendations. So what can be done to address this? The recommendation can be useful for policymakers to make a change. So this is the example of recommendations that have been created specifically for the policy. Some of them talk about putting in place like extended payment plan, making sure that there is no interest to that kind of accumulated debt amount. Also providing some, as soon as the policy goes into effect, providing some financial counseling to individuals who take advantage of that. So really thinking about what already exists in other states and the literature that can support some of the kind of evidence-based strategies to address some of the negative impacts associated with the policy. So, and at the end, kind of bring it all together. So the tool probably is about 7-8 pages when it's completed. Again, we understand that decision makers might not have time to go through the whole thing. There is an opportunity to create a 1-page summary that you can see here, which has the components about what is the policy name, what are the key points, what determinants will be impacted, what population is going to be impacted and how, and what are the key recommendations. So the idea here is just have 1 page of talking points and kind of as you're trying to present this information to the decision makers. So I have about 5 more minutes. So the next 5 minutes, I want to just show you some of the examples of how the tool has been used in Kansas and outside of Kansas. And examples will come from Chickasaw Nation in Oklahoma, some pilot projects here in Kansas. So in Chickasaw Nation, Dr. Parker, Commissioner of Health Policy in Chickasaw Nation, expressed interest in incorporating health in the decisions specifically for workforce community. And they were very interested in this tool, but they wanted to make sure that this tool meets the tribal nation needs as well, in terms of terminology, what the tool is actually trying to look at. So what they ended up adopting the tool, they felt that that's going to work to inform their decisions for the Chickasaw Nation with some tweaks. And I think these tweaks are really important for us in the public health community to consider. So in this table of social determinants of health, we call it social, economic, and environmental conditions to kind of stay away from jargon. They identified several other important determinants from the tribal perspective. So for the environmental section, they added preservation of tribal land is an important determinant that needs to be considered, when policies are made. In education section, they added determinants related to language and language preservation, cultural humanities, history and tradition. And then it also added under the community context, importance of traditional beliefs and practices in classes or workshop. So they added those determinants as they're gonna, again, use this tool to inform the implications of their policies. They will consider those additional social determinants as they go about it. One thing that they're still trying to figure out is how to define the populations of focus. I think I showed that broader list within their Chickasaw Nation. So how they really want to go, given that they have their main focus is on workforce community, should they go thinking about different levels of the organization from administrative to leadership? Should they also focus on demographics? So they're trying to really figure out what the populations of focus you use. And they actually did that using the term population of focus strategically. They try to stay away from the word vulnerable in order not to place, additional blame the victim approach. So we try to use, the terminology populations of focus. I actually be very curious to hear if there's a better term that this group were able to come up with to describing those who experience systematic barriers to health. So their next steps are piloted across the departments, and they already piloted that on their telehealth policy and incorporated some recommendations based on that. So the next one is Pathways to Healthy Kansas initiative. This is a very big initiative in Kansas, affects 24 communities. And they work done by Blue Cross Blue Shield of Kansas, or sponsored by Blue Cross Blue Shield of Kansas. The communities work on selected packages, like they're trying, for example, to improve food selection in pantries, making them more healthy, build trails, build sidewalks, and other changes. So one of the packages is actually implementing the health impact checklist. So to do so, they have to sign the pledge, complete requirements, and then they can apply for a grant to do this work. So this is the snapshot of a pledge, and each package has a pledge, and this one is specific to a health impact checklist that they just showed. So basically, in the health and health policies pledge, they have 5 options to choose from. They can like work on passing a health and policies resolution at the council level. They can do like health equity lens analysis of the documents, and then they can complete health impact checklist on policies. If they decide to do this particular one, on the right-hand side, you can see minimum requirements they have to do. They have to figure out how their city council, council commission going to use the tool, how it's going to become a part of the process. They have to commit to doing at least one analysis on one policy and figure out sustainability for about 5 years. So we have several communities like Franklin, Bourbon County, at this point, Crawford County, that are working on this particular package. And then another way that has been incorporated in Riley County, the Food and Farm Council, there was passed a health and policy statement. As a part of their statement, there was a general commitment to do health and policies work, consider health and equity in decision making, and health impact checklist was recommended as one of the tools to accomplish that. So this is just kind of a snapshot of the policy. So this is kind of another opportunity to make sure that health and policy is part of the kind of structural processes to put this in an ordinance resolution, or in this case, a policy statement related to Food and Farm Council. That's kind of the language that they used. And then lastly, one specific example from Bourbon County. So the former economic development, Jody Horner, and now she's a president and CEO of Healthy Bourbon Action Team. When the micro meat processing plant was coming to Bourbon County, it was a very controversial decision. And she has used this tool to inform and understand what would be the impacts on the community from health and environmental perspective, and kind of look at those all different determinants of health and then connect them back to health, and then present information to the county commission so they can make a decision what that would mean and what tweaks can be made if this plan does come to the community. So I know I'm at time, so I'm gonna stop sharing screen and pause there. And I know when we come to the time of questions, I look forward to answering any. Thank you for the opportunity.
Great, thank you so much, Tatiana. That was wonderful. I loved hearing all about all the work you're doing, the checklist and the application. That was wonderful. So look forward to the discussion later. And a reminder to everyone, drop any questions or comments you have in the chat. We love to have dynamic discussions in the chat as well. So great. Well, we'll now turn to our next speaker, who is Dr. Marvia Jones, who is the new, well, not new, but new to some, the director of the Kansas City, Missouri Health Department. So we're so privileged to have you. And she's going to share about some barriers in our own backyards from the KCMO Health Department perspective. The floor is yours, Dr. Jones.
Thank you so much, Dr. Farr, and thank you everyone for being here today. I've just really enjoyed the previous presentations, and so hopefully I can lend my perspective to some of the issues. When we think about health in all policies, one of the first things that comes to my mind is thinking about our own organizations that are implementing the work that we're trying, or the strategies that we're using to address the issues we've identified in the community. One of the things that we found here at the health department several years ago as we were studying life expectancy across our city and looking at the differences across the zip codes is we actually did a study to see what percentage of our staff actually resided in low life expectancy zip codes. And that number has varied between 50 to 60%. And that tells us a lot, and so that will frame a lot of the work. I also live in one of those zip codes, and so much of my experience will also come from that perspective. So I want to talk about barriers to equity and innovation in public health service delivery. And I want to clarify that or sort of hone in on how internal policies and practices impact our ability to achieve health impact. So after we've done all the community work that Ms. McKinney discussed, we've gone into the community, found out what we need to do. We've done our checklist, as Tatiana just finished talking about. We still need to figure out how do we actually get them going and how do we make them work? Because we usually start with the big ideas, but we know that it gets down to the staff level and we have to figure out how to make it happen. And so I'm going to talk about 3 key areas that I've defined as some of the reasons that we sometimes don't get as much traction as we would like, or we miss some ideas. We don't really get the impact that we maybe started out in the conference room thinking we had it all together, and it doesn't really flesh out. So one of the things is that we'll discuss is how key voices are often underdeveloped, folks who could assist with this sort of strategic thinking and planning and impact assessment. Key voices are excluded from strategic discussions. And then I'll talk about how key voices are not elevated. So when we go to the first topic of key voices being underdeveloped, and what I'm talking about here is when we think about who we can listen to when we're doing, if we think about the tops of our organizations, who weighs in on those strategic approaches? Are we going to go to this organization to start our discussions? Are we going to, where should we go to have our public meeting? What is going to be the sequence of our public meetings? What health issues will we focus on first? What will our messaging look like? When we think about those discussions and who's in the room, we know that some of the people, as I've mentioned before, who maybe often are parts of those communities that would benefit from the things we're trying to do, their voices are not, quote unquote, ready to be at the table in many of our cases. We don't include them. For one, we know that their background does not always lend themselves to having the opportunities that would have placed them in line to be at the top. And so they're not at those tables because they're working somewhere lower in the organization. They don't arrive in the typical packages, so they may not have the Masters of Public Health or the Masters of Health Administration or the Masters of Public Administration that we might be looking for. They definitely don't have a clinical background. And so we may not see those people as being those who we should be investing in to get them to the table. They can sometimes be underdeveloped. And so when they talk about their ideas or they are mentioning them in the hallways or they're talking in groups, we don't really hear them because we assume that they're not ready. And maybe they're not really developed in a way that would allow them to cogently, coherently express what their ideas are. And then our own unintentional bias around who is ready to contribute to those discussions can definitely make us assume that they don't have the capacity. They don't know the strategy. They didn't study the implementation science of it. They don't know the public health principles that guide our implementation of these strategies. We can sometimes assume that without valuing some of the lived experience that folks have. And so what we see is that folks who could actually contribute appear to be unready and unable to fully contribute. So they're not really there for us to. So our target or our goal here should be to avoid assuming that only those folks with those particular degrees or backgrounds are ready for the prime time of assisting with our strategic planning. And we need to make sure that we continue to expose all of our staff throughout the organization to development opportunities. How do we show everyone how to do presentation skills, or how to implement presentation skills? Even those folks who maybe don't do a lot of presentations in their current role. How do we show everyone how to do a grant application or how to do a strategic plan? If that's being offered, we should do a better job of making sure that that's accessible to everyone and not just that small group of people we've identified as being in line for that type of development. And the other goal here is to make sure, again, that we are being equitable with those opportunities across our organization. We talk about equity in health and we talk about innovation in health, and our health starts with so much of the hours that we spend at work. So much of our health is wrapped up in our workplace and the types of opportunities and the voices that we see ourselves as having in our workplaces. So moving on to the next topic of having key voices excluded from strategic discussions. And this kind of obviously relates to the other one. And what I'm talking about here is that there are people, maybe some of them even have the we're looking for, but because of when they came into the organization or who hired them and where they were in their lifespan and why they took a particular position over another, or why they needed to do so, they still are not invited to contribute, even though they may have some of the skills we're looking for. And we sort of fall into this pattern, as I mentioned before, of assuming that all the knowledge and expertise is going to be at the top of the organization. For instance, in my case, we have, there's the director role, then there's the director, the deputy directors, then you have division managers, then you have some additional managers, program managers, then you have your frontline supervisors, and then you have frontline staff, and different areas may differ, but it would be very foolish of me as a director that is overseeing the work of a department that is between 50 to 60% of people who reside in low life expectancy zip codes. It would be very foolish of me to assume that the knowledge about what needs to happen exists only between myself and those other two layers. And so it's something we constantly talk about as a leadership team, making sure that we push that power down across levels, empower everyone, hear everyone's voice, and be very intentional about saying, hey guys, what do you think we need to do? What do we need to do in this situation? Here's our challenge. You tell us what you think could help. And it takes a lot of practice, and we're not perfect yet. No organization will be, but something that we can be intentional about. And so what the problem with sort of these negative assumptions, or just these unintentional biases that we might have, is that we are making judgments. We're making whatever strategic decisions we make, we're basing it off of what, I know there's an argument in the literature about using the WEIRD acronym, as you know, which stands for Western, educated, industrialized, rich, democratic, so much of what we learned in school for our MPH, MHA, MPA, PhDs, so much of it is based off of data from people who signed up to be in studies. And we know that that is not always a very representative example of everyone that we're trying to serve at the current time, wherever we find ourselves situated. So we know that we're already, if we only rely on our training and kind of what we have been told as best practices in our fields, we know that we're only receiving an incomplete picture. And so we have to bring those voices in because we'll be missing out a big part. And it makes sense that if we are using our training only or our best practices in our field, then we are basically saying that we know how to reach the people that were studied in those studies, but we are missing out on how to reach the people that we're actually serving. And so we will definitely have some blind spots. So our goal here is to avoid assuming that these practices are always going to be applicable to novel situations. What we found when we looked at COVID-19, which was a huge disruptor, and we looked at how we all scrambled to meet the needs of our communities. So here was this prime example of people weren't acting the way that we wanted them to act based on what we had learned in our careers. We learned about, I'm an MPH, my background is in public health. So we learned about Dr. John Snow and how he went and found the issue with the one water source and how it was contaminated and how people were getting sick. And so, he did that. And then the other guy who discovered the smallpox, and he figured out what was going on and who was working with the cows and who wasn't, and lined everybody up and started giving them the inoculation, and people just did what they were told. This was a novel situation. COVID-19 happened in a different time, in a different place, where we have different philosophies, different values. We also know we have quite a bit of inequity in our society. And so that blew all of our training out of the water in many respects. We found ourselves scrambling to respond in a very different way. Suddenly we had to figure out, how do we stop talking as if we're all talking to fellow scientists and researchers and public health geeks, and really think about, how do we put terms like immunocompromised and immunity and herd immunity? How do we put those in terms that the average person can understand? We know science education has been cut back in the educational system. We know that there had been this burgeoning thread of anti-science even before COVID-19. And so we found ourselves in a unique situation. And there, where we would benefit most is to learn from those people for whom those people are their neighbors. They know people, they have people in their, we all have people in our families who are like, I don't know what y'all are talking about. That doesn't make any sense. We know that is definitely a part of our society. And so we have had to use novel approaches, and we're still learning to implement some of those novel approaches that our training couldn't really get us out of alone. We had to have that people element to it. One of the things we think about is that it would be helpful the next time something like this comes around is for us to talk to our entire organization. Hey guys, what are you hearing on the ground? How do you think we can best communicate what we need to communicate? And so our targets here are, again, just that, to make it an ongoing practice to engage frontline staff in strategic discussions, share information about the context and its challenges. So we want to share with them, hey guys, here's the briefing of where we are today. These are the biggest issues. This population, we're not being able to reach for the vaccination, this age group, this part of the city. Hey, what do you think? What do you got? Because we're running out of options and we're needing to pull in other voices. And that is something that you never know what you will get from something like that. Someone might give you something you hadn't thought about before. And then the last piece is about key voices not being elevated. And so here we're talking about those very highest rungs of an organization. And we know that as much progress as we've made, which has been plenty, we know that unintentional bias, whether it be socioeconomic or racial, ethnic, or gender orientation, we know that still a typical organizational leader that is presumed to be the voice or the one authority on everything. And that can get us into trouble when that's the voice we listen to, because what that does is it creates this hierarchy, a very rigid hierarchy that elevates only a few of those non-representative voices. And that can make the whole organization feel like my place of work is not open to new ideas. Why bother? I don't need to contribute. Only the people that the person at the top believes in or trusts, only those people have a say. I'm not really valued. I know that my neighbor said this the other day or did this, or this policy they came out with last week. This is how my neighbor is implementing it, or this is how my church misunderstood it. But it's okay. I'll let them do what they want to do. I'll let the leadership folks lead, and I'll just leave it alone. That's not going to help us get to innovative strategy. It's not going to help us get to equity and health outcomes. And it's certainly not going to create a rich, fertile ground for innovation that will take us into the next phase of public health. So here our target is to remember that promotion and hiring decisions have consequences, and they do send a message to line staff. You know, if people continue to see the same folks being denied potential opportunities or the development that would get them in line for those opportunities, then you continue to create a system where people don't feel like they have a voice and that their voice doesn't matter. So we definitely want to be careful of again, going back to development opportunities and making sure that people are getting what they need so that they can be cultivated. I find that if you've had an employee and they've been in your place of work for 10 to 15 years, they've been in the same role for that whole time, and no one's asked them, hey, what are your aspirations? What would you like? What do you need to work on? Then that's a problem. That's a problem of leadership. If you have folks in your organization and no one's asked them that, then it's very likely that they will not choose something different. They won't feel like it's available to them. And it is our job as leaders in our organizations to ensure that they have those opportunities. Any type of feedback that we're providing, most people have a performance appraisal process. We're big proponents here of making sure that we give honest feedback to people, because not giving that feedback to them is really robbing them of an opportunity to improve themselves. And if they can never improve themselves and show and shine, then they don't have those opportunities to be placed into positions where they can have a huge impact on our equitable health outcomes. So that is what I have for you today, and I look forward to any comments or discussion. Thank you.
Thank you so much, Dr. Jones. That was phenomenal, and I'm sure we'll have some rich discussion on this. I think you said a lot of the hard things that a lot of us know, but I don't mean to sound like that, but I mean, like, we know we need to do that. And the way you framed it is, gives us the right message and exactly helping us kind of start to think about how we're going to actually move toward making that a reality, because we know that it's extraordinarily important. And I think, you laid that out really well. So thank you very much. And next, and so yeah, please everyone do drop your questions or comments into the chat. And from here, we'll now turn it to our final speaker before we have kind of the Q&A discussion and panel discussion here. So we now have policy perspective, where we'll be hearing about health and all policies, cross-sector work to step out of the silos and into the community from Corey Kako, who is with, looks like a few affiliations here, environmental health officer with the United States Public Health Service, stationed at the Agency for Toxic Substances and Disease Registry, or ATSDR, and also regional representative Region 7 with Kansas City CDC. So Corey, thank you so much, and the floor is yours.
Great, thanks. Can you see my slide?
Yes, sure can.
Okay, great. Hi, yes, I'm Corey Kako, and yes, I am an acronym soup because not only am I stationed with the Agency for Toxic Substances and Disease Registry, we are a sister agency for the Centers for Disease Control and Prevention. And I worked a lot on COVID for all these discussions. I was deployed actually about 295 days with the CDC COVID response as the Associate Director for Science at one point. So anyways, I wanted to talk to you guys today about health and all policy. And we talked earlier, I think it was maybe Tatiana, but mentioned that the ASTO definition. But I do want to bring up that there are a couple other definitions, both at the National Association of City and County Health Officials, kind of reflecting a change in the systems, determining how policy decisions are made. So this idea of moving us forward and having change, or the WHO's with integrating considerations of health, well-being, and equity during the development. And so I do want to point out that there are a couple of different definitions here. And in general, the goals of health and all policy, they're upstream. Okay, so in other words, we're trying to change how we implement policies, programs, services, so that we can consider the health impacts earlier in the decision-making process, right? We're public health. What is public health supposed to be about? Prevention. We're supposed to prevent things, right? So these health impacts earlier, promoting positive health impacts and minimizing potentially negative ones. Health in all policies is also comprehensive. It involves all sectors, from the Chamber of Commerce to the health department. It involves the entire decision-making process, from development to evaluation, and it involves all levels of government, from local to federal. So there are 7 health and all policy strategies. These came from NACCHO, and one is developing and structure cross-sector relationships, so tactics for developing and structuring these relationships that can be formal or informal. So formal could be things like councils, committees, task forces, but informal can be just a temporary work group or voluntary team. Enhancing workforce capacity. I know that Marvia was talking about this earlier, creating opportunities for staff to interact across sectors and with external stakeholders. Implementing hiring practices that incentivize collaboration with partners outside of the health sector. Hiring non-traditional staff, such as planners, or identifying specific staff to administer and sustain partnerships. Another one is incorporate health into decision making. And an example of this is doing needs assessments, strategic planning, priority setting, and for local health departments, health impact assessments and community health assessments can help incorporate health considerations into land use or transportation policies, by informing decisions or developing strategies to avoid or mitigate negative health effects. Number 4 would be coordinate funding and investments. So cooperative agreement, funding announcements, contracts that include health criteria, or for non-health sector applicants, review and score funding applications that weigh the inclusion of health objectives. Number 5, integrate research, evaluation, and data systems. Data from research and evaluation projects can identify potentially impacts of cross-sector policies on health and opportunities to maximize positive health impacts. So, for example, cross-sector data and indicators such as access to parks and healthy food and health data sets include health integrated indicators in program evaluation and use data to validate health performance measures. Number 6, implement accountability structures. Accountability structures help organizations and their partners sustain these health and all policy efforts in the long term by assigning responsibility and ensuring transparency. And number 7, to synchronize communications. Communication is the foundation for building a common vision across silos. So ATSDR has a couple of ATSDR, again, acronym soup, at Agency for Toxic Substances and Disease Registry, has a couple of tools, including we have a community engagement playbook. It's a guide for health professionals and public or private partners to bring a community's knowledge, needs, and preference into the decision-making process. We also have a brownfields or land revitalization action model. And I'll be talking about 2 examples where I used that model. The community engagement playbook is new. I encourage you to just Google it, look it up. You can just type in ATSDR community engagement playbook or ATSDR action model, and all of this information will be available to you. So I was going to talk first about some work I had done in Joplin following the tornado with the ATSDR action model. So, of course, in 2011, there was a nearly mile-wide tornado that struck Joplin. It killed over 160 people and severely damaged structures in the city. But it also picked up, this is something you might not realize, but Joplin is an area with historical mining and smelting. And there were a lot of what we call chat piles. And so there was a lot of lead piles. You can actually see these piles from space in some of these areas. That were literally picked up by the tornado and redistributed as well. Also, during the tornado, the school was destroyed, and one of the hospitals was actually picked up from its foundation and moved over. And so EPA asked ATSDR to come and assist with what they called a complete streets design, but we went further, ATSDR did, during this. So the complete streets was relooking at the 20th Street corridor, which is where the high school is and now where a public library is, but they wanted to create this idea of having a walkable community. They wanted community features, things you could not actually walk to the high school before. There were no sidewalks that could have gotten you from any of the neighboring communities, and none of the neighborhoods right there next to the high school. You couldn't have walked. There wasn't a library that was there. Their library was downtown before. And so they had all of these wants and desires. And the interesting thing that occurred is when you hold a community meeting, you're hoping to get input from the community, but who actually shows up to the community meeting is not necessarily your stakeholders. It's not necessarily the people that this will impact. And what we originally found when we had a couple of community meetings was that the demographic of the people that showed up on this corridor that we wanted to place a high school, that the city was hoping to place a high school on and have it a complete street and have it safer and everything, is over 60. Almost everybody that showed up to these meetings was over 60. There was no children, no families with children. There was, and that demographic did not want that street to change because, you know why? That was their cut through street. That was their fast street where they were going to be placing the high school after the tornado. This is where they like to speed through and cut through into parts of the city. And so we had to kind of think outside the box and look at how we were going to get community buy-in. And so we started looking at this health engagement of what are people wanting in their community. There were people that wanted to get around without a car. Well, you need sidewalks to be able to do that, or you need bicycle lanes, right? People wanted access to nature, and yet in the original public engagement sessions, we were only getting people that wanted to be in their cars. So we went to some Third Thursday events. We went to a couple of places where we met the community where they were at, and we got some of these these things that people were looking for. So we also created, or I created a very large land revitalization action model that kind of looked at a lot of different things. So you can kind of break it down to these four themes here. We're develop and structure cross-sector relationships. So I worked with the Citizens Advisory Recovery Team, the CART team, worked with County Parks and Rec to plan park and trail linkages where you could have rails to trails and some of those ideas. The tree board, because the thing is, the trees were all knocked out during this tornado. They were all ripped out. And so you don't have shade. You just have, it is hot in those areas. And so the tree board for reforestation, to work on this heat island, where it's just hot sun. And so you don't want to walk, even if you put a sidewalk there, you need to have some shade. And also another organization that's looking at physical activity initiatives in both Jasper and Newton County. Joplin actually sits on both of those counties. We also looked at post-disaster school displacement. I mean, these kids had been redistributed through all of these random schools and warehouses and all kinds of things for those last couple of years. Until they were able to rebuild the school. And so we were working with local schools and city planners to look at this Safe Routes to School program. And we were able to set them up with that. And that had to do with sidewalks and everything. The lead exposure issue that I had mentioned before, and we working with our EPA partners and also Missouri Department of Health and Senior Services, as well as the local health departments in Newton and Jasper County. And we're still actually working on this issue. ATSDR is working on this issue right now. There are things that we're doing right now at this moment, whether it's super fun work or looking at blood lead levels in children due to a lot of the things that happen with this. And also those mining and chat piles. So into this incorporating health and decision-making processes. So, and wanting to be able to do new development, redevelopment on these remediated sites. So moving on. So there was another place that I worked down in the boot heel of Missouri, which was Howardville. And this is a community of former sharecroppers. It's down by the New Madrid area. And this community had a lot of concerns, but everything came back to them for wanting to have a better place for their children. And so children's health concerns were their biggest, was the biggest thing. There are only, gosh, I can't remember if it's 185 or 300. It's definitely less than 300 people that live in this community. And I had 12 people that came every day for 3 or 4 days that they developed their own action model. They sat in classes with me and training with me, and they developed what they wanted to see. And a lot of the things is, do you see that Howardville High School? That actually meant a lot to them because that high school actually, they chose after segregation, they wanted, this community of sharecroppers wanted an all Black high school to share these important historical beliefs and this community. And this was an important thing for them, where they had this high school and they wanted to be able to save part of it. Also, there's a lot of petroleum in down there, and these residents, this is a food desert. This is a health desert that you have to drive a long way to get anywhere to be able to get food. They have a soda fountain. That is the only thing. They have a soda machine at their little town hall. That's it. That is the only thing that you can purchase in this little town. It is soda. And so there was also some concerns from some of the age of the housing in this community of lead. And so we actually also conducted a soil testing event during my time with these people. So, but they were looking for that preservation of that school. So we were trying to coordinate funding and investments for them, technical assistance grants for EPA cleanups. And there were 2 different grants that they ended up getting and working with EPA with this. We were connecting them with underground storage tank assistance, trying to enhance workforce capacity. And these were all ultimately, like I said, these were goals, and these were things that the community members created. They created this whole plan for their community. And there were, you know, like I said, there were 12 people that came every single day because they had such a passion for how they wanted their community to be redeveloped. So, and again, also, as I mentioned, this action model toolkit, and actually one of the community champions that's with the Howardville Betterment Corporation, I think it's called, or something like that. It's wonderful nonprofit that Vanessa had started, but she ended up being also part of a community partnership group that we work with at ATSDR, and kind of being a face and a voice for rural communities and minority communities and small cities. And so that was so important with all this valuable history they have there. So as I'd mentioned before, with ASTO, this is taken from the 2021 ASTO Health Officials Report, Framing Health in All Policies. And sometimes it's the narrative of the health issue that resonates with non-health partners, and framing this as a process, not just a policy. And, you know, it makes me think, you know, one of the things, a lot of this stuff is so connected, right? So you have concerns of drug use or violence, but then you also look, I mean, there was no activities to do in Howardville. There was no other outlets. And so you're looking at this, you know, from more of a upper level view sometimes. And so encouraging non-health partners to take leadership role. And that was Vanessa from this community, where you have sometimes a community champion instead of the state, local, tribal, territory health authority. And you know what? Whenever you can get a community champion, and it doesn't always have to be somebody from the community, but when you can get a community champion, you have such a better chance of it being sustainable and getting the community to take it on and to take ownership on this, and bring healthcare into the conversation by developing tools for evaluating these partnerships and collaborative efforts. So here are a couple of tools and resources. Here's the ASTO resources on health in all policies here. Here's the NACCHO resources and toolkit here. And you can just Google these. And that's it for me. And we do have a website as well at CDC. Again, that ATSDR CDC thing, we're all kind of connected, so same thing.
Great, thank you so much, Corey. That was dynamic and very engaging, so and informative. All of our speakers, this has been incredibly informative. I'm sure everyone here on the call is agreeing. I would like to take this time to, you know, allow anyone on this call to come off of mute and to ask a question of the speakers. But, you know, and just before that, you know, just kind of reflecting, you know, we've really kind of heard from, you know, a number of voices here, and we've, you know, heard a lot about, you know, what is HINAP, you know, and how do we engage stakeholders, ensure all the voices and the right voices are heard, but not just that they're heard, but they're actually incorporated into how a program or policy gets put into place and is operationalized. You know, and then some of these different tools, like, you know, the health impact checklists and a lot of these tools that have been shared. So hopefully those are really helpful for anyone on the call that's working in this space as well. But you know, another thing that we've kind of heard a little bit, and that a lot of this work really kind of relates to, is really how we start thinking about, you know, moving these policies, even, you know, then once they're put into place, into practice, you know, and how do we actually use the tools. We've heard this from a number of speakers, the tools of implementation science, so that we can actually use best practices to overcome barriers and put certain strategies in place so that we make sure we're delivering the policies and programs, you know, as intended, to the right people at the right time in the right way. And, and I always like to think about that. I'm sure some of you can relate. The whole Schoolhouse Rock, how a bill becomes a law. Well, how does a law, once the law is then created, how does the law become a program? And so I think that's kind of an important piece here to think about as well. How do we actually get something that is a program operationalized in the right way, to reach right people? And I thought, Marvia Jones's presentation on, getting the right voices and all the voices heard, because I think that's something that I don't think is really been pinpointed in a lot of the discussion that we've had on health equity in terms of, who is at the table and who from within the organization, and getting people at all levels and making sure we're thinking about promoting and developing people from all levels. So there's just been, this was really rich. I think it's touched on so many different topics, but, health and all policies is broad. So that makes sense. But there were a couple other things I wanted to say. One that I thought kind of everyone here on the call, all the speakers would be able to speak to, would be really talking to us a little bit more about, we hear and we've heard from every speaker, we need to engage all the right stakeholders. We need to partner with all the right, people who are the end users or recipients of these policies or programs. But, that can be in many flavors, and we've heard some of the flavors, but I would really love to hear a little more from the panel on what are some of those good strategies for engaging all the right people at all the right levels in the right organizations as we're, creating these policies or programs.
This is Lana McKinney. I'll start. One of the things we did for the community listening sessions was use that exact framework. We needed to have a diverse group of voices at the table, and we weren't isolating diversity in one sense. So we looked at a low life expectancy, high life expectancy, every generation that's currently alive. Organizations that have been involved and some that are too small or hadn't been previously involved or felt they were too small to engage. And so a simple reaching out and saying, I know you may have had your voice at the table, but we'd like to invite you to have a conversation. A lot of times when people hear, can you take a survey? We want to come into your neighborhood or into your community and provide, can you give us feedback? One thing we ran into was a specific sort of couple of zip codes said, we're tired of giving feedback without someone listening. And so what we recognized was asking for an assessment, asking for a survey wasn't the approach that was well received. So we sort of took it a step further and say, okay, I hear what you're saying, tell me more. And so engaging in more of a conversive way was how we moved the needle, and taking into account that there were some communities who had their voices recorded, had things, told to other researchers that they didn't want to repeat. They felt like nothing was working, nothing had been done. And so in knowing that, we didn't approach it as, can you take a survey? Can you take an assessment? We went to we met people where they were at their neighborhood association meetings, at their community events, at their centers. Instead of asking, can you come to this session? Can you come to this listening session? Can you meet us where we are to hear your voice? Instead, we sort of flipped it and said, we're going to come to you and all we want to do is talk. Or we're going to ask you a question and all we're going to do is listen. We're not going to tell you anything. We're not going to tell you what you need. We just want to listen. And so being okay with some of the feedback that we received was probably the greatest approach and the most effective, because once we came back, and that was the follow-up was really necessary. It took us a year, almost a year and a half, to create the Community Health Improvement Plan. A year and a half later, we show up to these meetings saying, hey, here's the document we talked about. Do you remember having this conversation? Do you all remember us engaging with you? Some did, some didn't. But just to show up again and say, this is what we talked about a year and a half ago. Here's it in black and white. Here's now how you hold us accountable. And that resonated. So.
Lana, I absolutely agree with that. I think that that's just fantastic. And the other lesson learned that I've had over time is making sure that I'm not listening to a vocal minority who is not the one that's impacted. I need to make sure that the vulnerable population, whether that's children, minority, whoever it is, and sometimes it's chemical specific for us or whatever, but who is vulnerable in this situation, and to make sure that those voices are being heard. And I do want to make one other point, that when I work with tribes, I always want to make sure that I don't promise what I cannot deliver. And because of this legacy of distrust and legacy that our country has done to our tribes, where we have made promises and broken them over and over and over again, I try to be very careful with my tribes to only promise what I can deliver, and to tell them I don't know if I can do this, but I'm going to try if I don't know. So to be transparent.
One point I would like to add real quickly, and definitely agree with all the presenters, is that I think as researchers, we need to not come with like developed questions. We should really engage and ask what questions we should be asking. And in addition, I think it'll be really important to kind of engage that kind of really up front, suggest how we should collect data and what measures of success you think we should be setting. So in a lot of cases, when we evaluate projects, we come and say, okay, here's the process measures, here's the impact measures. I think it's really important to ask, how do you think what our success looks like to you, what measures we should use? And that can really help with that engagement and trust, and honestly get the better results and more authentic results in the end.
And the last thing I would just say, in conjunction with everything everyone else has said, is that I think practice, from an internal perspective. So some of us have diverse populations in our own organizations, and being able to, once we really kind of master the practice in our organizations, we'll be when we go out into the community, in part because we've kind of flexed the muscle, but also because the people who are in our departments or our organizations become better ambassadors themselves. They call their neighbors and say, hey, you should come to this meeting. The place where I work is doing this thing. I want you to participate in that. And so that opens up many more avenues for all of us, but it does take a lot of practice, which is saying, hey, let me throw this out there and ask you guys the question about some decisions are going to be big and some are going to be small. But when it comes to health equity for communities, I think we have to just bring all those voices in, and it starts at home.
Yes, that was very well said. Great. I don't want to dominate in case there's anyone here on the line that wants to come off mute and ask a question, but I have another as well if no one does so far. So interrupt me if you so do, but I was going to ask also, for example, Tatiana, how you've mentioned, instead of kind of bringing maybe these checklists or something like, to certain populations and asking specifically about process or outcome measures, et cetera. I loved that, what does success mean to you? And that's really a lot of this, using community-based participatory research methods and things like that. But really, I think, asking what does success look like to you, I think is, extraordinarily important. And, I would just love to ask the panel in terms of, us as a community here in Kansas City, and how do we, kind of move the needle first. I know, Marvia just gave some really concrete, wonderful examples of that for starting to get towards success. But, was anyone else like to add any other kind of concrete examples of how, action steps, everyone here on this call, and that we can share with our organizations, et cetera, in terms of what success looks like, so that we are appropriately incorporating equity and health in all of our programs and policies that we deliver. Some magic bullets. We're all just ready for a few quick ones. We know there's not quick answers, but any tips or advice?
One potential, I know it's already happening, but kind of continuing on this breaking the silos, aligning efforts, maybe incorporating more to leverage funding across agency, cross organizational strategic planning, kind of how we always drive at the same goals to the extent possible. I think would be kind of additional step that can help to get closer to those goals.
I see nods and no other chime ins. I'm gonna, okay, so we'll stick with that then. And, you know, I guess in the interest of time and knowing a few people are, you know, starting to have the 4:30 ones to get ready for and need the restroom break between. So I just want to take this moment. This has been a fabulous session. I really just really loved the voices everyone brought to the table. I thought it was everyone really complimented one another and kind of speaking to how we can better incorporate health and equity in all policies. And so I really thank everyone here on the call for your time, for your expertise, for the work that you do. And I just want to, you know, invite everyone to our next monthly forum. Remember, we do have these every month and not prepared in advance. So that one is on July 21st. So please do join us. That one's from, again, 3 to 4:30 and is on alternative payment models. And so this one kind of looks at different payment models as we kind of navigate out of, you know, fee for service into some more value-based and alternative payment models for healthcare delivery. So thank you all so much. We appreciate you all.